All right, so we're going to do a quick run through some of the benefits of the blocks that our last speaker was addressing. I have no relevant disclosures. So the objectives for this talk will discuss briefly the benefits of regional analgesia that have been proven over the years, quickly talk about truncal block anatomy, and then more specifically talk about the evidence for the benefit of TAP blocks when you're talking about abdominal surgery, since that's what the bulk of you are doing for a living. And when you look at the various modulations of pain that were talked about by our first speaker, we're going to specifically address the sensory afferent pathways. So you block the signals from ever getting to the brain to begin with, which can also be beneficial for further down development of chronic pain if you're not activating these pathways. When you look at a lot of the literature for regional analgesia and anesthesia, a lot of it's included in our new enhanced recovery bundles that have become quite popular over the past decade or so. And overall, you're able to show typically benefits of decreased pain, decreased or eliminating opioid use, reducing nausea, getting people out of bed, recovering GI function, decreasing length of stay, and decreasing the surgical stress response, which really is the whole principle behind ERAS protocols. But part of the problem is a lot of the literature tends to be, okay, we've put together this ERAS bundle, we're going to throw TAP blocks in there or some other block, and we're going to show that it works. And it does, because you've just thrown about 10 things at the patient. Most of the studies don't necessarily compare the individual components, although you'll see later in my talk that we've gotten a little better at parsing some of that out. And the other problem is the more things you put into a pathway, the less likely it is that every single component of that pathway is going to get hit, right? So the more complex, less compliance. And regional techniques are not risk-free. You are sticking needles into people, right? So there's going to be some drawbacks there as well. The old classics is the epidurals, right? And I think we're starting to see less and less of that, more so with laparoscopy, where I will just say it's overkill for the most part, but even with some open surgeries. And so the evidence, again, overall will show a tendency towards return of bowel function, less pain, and less overall complications, particularly cardiopulmonary. Plus minus length of stay, there's a lot of arguing back and forth in the classic literature for that. And so this is where you started seeing a lot more TAP blocks coming into play. And why did they get so popular? First of all, you're talking about, it does cover the area of interest here. You're talking about a truncal block that helps with abdominal surgery. The other thing is we're increasingly attentive to things like post-op anticoagulation, so we don't want to worry about having something in the neuraxial space. And then the widespread adoption of ultrasound to assist with these blocks and putting the local into the right space. And if you're comparing something like a TAP block versus a rectus sheath versus a thoracic epidural, the epidural is going to cover whatever dermatomes you end up with for your epidural level, right? It's a pretty solid block. That also means you're going to get some motor block with that, as well as other problems such as urinary retention, hypotension, things of that nature. The middle there, the darker circle, is a rectus sheath distribution. That will sometimes come in handy for more obese patients where the transversus abdominis plane can be hard to visualize, and it's good for something that is really centered. The lower half circle there is sort of the classic bilateral TAP block distribution, and again, covers a lot of what you all do. You can do a higher intercostal TAP block, or subcostal, excuse me, to cover a higher level of pain management there. But we're going to talk mostly about the TAP block since that is really the most popular out there at the moment. Again, this is abdominal wall analgesia. There is no visceral coverage. That's another difference with an epidural. So you do need to use other modalities in terms of systemic medications, typically done with either bupivacaine or ropivacaine. Pretty high volume block, usually 20 or 30 milliliters per side. The coverage is going to vary a little bit depending on where you place it. And the nice thing is you can do this in a supine position. You're not having to move the patient around, particularly if it turns out that you're doing this maybe post-op as a rescue. I'm not going to go into the entire methodology. That's a whole course in and of itself. But again, you're seeking that plane between the internal oblique and the transversus abdominis muscle. What you'll see below there is peritoneum and bowel. So again, these are not risk-free. You are pointing towards things that you can puncture. They typically last anywhere from 6 to 8 hours, can be longer depending on what's being done. And they also can be a bit challenging if you're trying to do this for laparoscopic procedures. Once you get air in various planes, that can kind of distort the ultrasound view. And again, with morbidly obese patients, you may be better with a rectus sheath, as that's a little bit easier to visualize. This is an older, well, getting older paper that looked at TAP versus like everything. They just took every paper out of the literature and said, okay, versus placebo, versus epidural, versus whatever, how does it look? And if you go down to sort of the summary statement, you can see that it is on the side of favoring TAP, but that the confidence interval does cross over the midline. And that's partly due to the fact that these studies are so heterogeneous and comparing to so many different things. There's a fairly recent study that just came out that actually did a randomized controlled trial head-to-head with epidural. And this is out of the Clinical Outcome Center at Cleveland Clinic. They are very good at doing these sorts of things. And this was comparing TAP blocks with liposomal bupivacaine versus continuous epidural for major abdominal surgery. Could be either elective, open, or laparoscopic. And as I said, it was randomized. And what they found was from a pain score result that the difference was non-inferior. So epidural or TAP seemed to work well. Then they looked at morphine equivalents. And what was interesting was the TAP block did need more morphine, which is not incredibly surprising. Again, it's a different sort of block. But the authors felt that the difference of 7 milligrams a day, which is what the TAP group needed, was not clinically relevant. So you can choose to interpret that however you want. I think what's more significant is when you're looking at side effects, you are getting things like more hypotension in the epidural group. So you sort of have to balance what you care about when you're looking at the two different sort of pain procedures. Then you look at something simpler. Let's go the other end of the spectrum, just doing plain old wound infiltration. And I'm a big fan of putting local anesthetic in wherever. To me, it's low risk for the most part if you're just doing wound infiltration, as long as you're paying attention to the dose. Why not give it a shot? And this is looking at specifically for inguinal or infraumbilical hernia repairs, TAP block versus wound infiltration. And you can see on this, they actually, with this meta-analysis, it did come out on the side of TAP block. So again, are you going to do this in every case? Maybe not, but maybe if it's somebody who's a bit higher risk, for whatever reason, it might be worth the time to go ahead and do that TAP block. You can see that when you look at the individual studies, several of them don't really show a difference. Another paper where I thought the author conclusion was interesting. This was addition of TAP block to an established ERAS protocol. So unlike where they threw everything in at once, they had already established ERAS and then they added the TAP block to that. It was retrospective, it's single center, so take that for what it is. And these were all pre-op anesthesiologist performed ultrasound guided TAP blocks. And what they were able to show, these are bariatric patients, so for roux-eyes and for lap sleeves, they were able to show a decrease in opioids, antiemetics, and discharge time. But then in their conclusion, they said it didn't have enough of a difference to meet their criteria, which was a 25% drop in all these factors. So they concluded that it was not a significant improvement. So again, I don't know, I think these numbers look pretty good. And they were able to show that it did have an additive value. This is another sort of similar where they were adding TAP blocks sort of later in the game. They called this a natural experiment. It was 2 hospitals in the same system. I'll sort of spoil the surprise and say it was the General and the Brigham, because that's what it was. And what they basically were doing was saying, okay, one hospital didn't change their practice, the other one started doing end of operation TAP blocks, either the surgeon doing a laparoscopic approach or anesthesia doing an ultrasound approach, compared it to the control hospital, and looked at the differences. And you can see there that both the morphine equivalents as well as the length of stay improved in the hospital that started using TAP blocks. The laparoscopic guided taps, I know we talked about that briefly, definitely an option. The main risk is that it's just not going where you think it's going, because if you end up preperitoneal, you're not going to get in that plane and get the block that you want. So if you see a really big bulge when you're putting that needle, or excuse me, injecting the local in, you're probably in the wrong spot. So it does take a little bit of practice. You may even want to work with your anesthesia team that the first few times you do it, you do have an ultrasound view and get the feel of where that correct plane is, because really you're just sort of doing it by feel when you're doing this laparoscopically. But there's some literature that shows that on comparison, that this is an effective approach. And at the least in this colorectal study, it was felt to be non-inferior to an anesthesia-performed block, and obviously, can be quicker than having to set all this up with ultrasound in pre-op. This is another more recent study looking at open ventral hernias. And basically, this was specifically for surgeon-placed blocks using liposomal bupivacaine, and showed a decreased length of stay as well as a bit of a decrease in morphine equivalents. So again, as I'm saying, put local somewhere, it should work. And then, on the other hand, do you have to go to the trouble of doing a tap block for every single thing that comes to your OR? I'm not going to advertise that. I mean, as much as, yeah, I like, my department can bill for it, so we're cool with that. But it's, we really don't need to do this for everything. And this was a study looking specifically at lap choles. Again, nice randomized placebo control. They did a quality of recovery assessment and did bilateral, subcostal, and lateral tap blocks, and basically showed no difference in quality of recovery or analgesic outcomes. So again, you want to pick the right patients and the right procedures for these. Something like a lap chole, if you're already doing multimodal pain management, which they were, you may not need to necessarily add something as complex as a tap block. And then finally, just they may not let me in the exhibit hall after this, but there's a lot of arguing going on in the literature about liposomal bupivacaine versus plain bupivacaine. There was an article that came out in the anesthesiology journal, I guess it's been a year now, in February, where the editorial that accompanied the article was fairly strongly against liposomal bupivacaine, felt that the evidence didn't really show that it made that much of a difference, that many of the studies, because they were industry sponsored, perhaps were biased. The jury is literally still out because the company actually sued the journal and the authors, and it's now in appeal, so it's interesting. But just this meta-analysis was felt to be pretty reasonably well done, and right now they're not saying there's much of a difference. So in conclusion, regional anesthesia is a valuable part of any multimodal pain management strategy. TAP blocks specifically appear to be non-inferior to epidural and superior to local wound infiltration. Overall benefit probably depends on what you're doing and how. And remember, again, it does not treat visceral pain, so you do need to use it as part of a multimodal plan.